Welcome to SCAI. My name is Bob Sommer from Columbia University, here with Matt Price from Scripps. And we have been given the enviable task of reviewing for you at this industry satellite webcast sponsored by W.L. Gore and Associates, the 5-year follow-up data from the REDUCE PFO stroke trial, which was just published in the New England Journal of Medicine. I'm going to start out reviewing a little bit of the background, and then Dr. Price will go into the results of the original REDUCE data, and we'll follow up with the new data from the 5-year follow-up, and then we're going to have a fascinating discussion. So starting back around 30 plus years ago, this was really cutting edge medicine. The whole idea linking PFO and stroke was really the next frontier at that time, which all started with the development of transesophageal echo. And in 1988, within a couple of months of each other, there were 2 papers which were published, both citing the increased prevalence of patent foramen ovale in young, healthy patients with cryptogenic stroke. In this population, less than 55 years of age in the 2 studies, the prevalence of PFO was found to be 40 to 60% by transesophageal echo with bubble contrast studies, compared to 20 to 25% of the population. And this really started this field moving forward. Subsequent observational series demonstrated a really high rate of recurrent stroke in this population. If you don't give them therapy, here's a typical one of those bubble studies with the flap of the patent foramen ovale opening and allowing flow of this agitated saline from the right atrium to the left atrium. And recurrent stroke in this population was presumed to be due to paradoxical embolization as the mechanism of stroke. Thrombotic material normally found in the right atrium was able to cross through to the left. It was very rare that there would be a case like this where you'd see a thrombus straddling the PFO, but clearly this was consistent with the diagnosis of paradoxical embolization as the mechanism of stroke in these patients. That led in 1992 to the first publication of transcatheter closure of PFO after presumed paradoxical embolization. And interestingly, this original series was done using the BARD clamshell device, which was a pediatric ASD closure device. And all of the doctors on this original study were pediatric cardiologists. So this was first presented in 1992. And for the next 3 decades, the management of patients with PFO and stroke was an incredibly bitter, controversial subject, kind of pitting the stroke neurologists who wanted to manage these patients more conservatively with medical therapy versus the interventional cardiologist who said that if it's broken, we have to fix it. And this is the kind of level of animosity that came out of this. There were published papers talking about the conflict between neurologists and cardiologists. But that all ended when 3 randomized trials were published in the New England Journal of Medicine on September 13th of 2017, the RESPECT trial, the REDUCE trial, and the CLOSE trial, which conclusively demonstrated benefit of PFO closure with ongoing medical therapy compared with medical therapy alone. All 3 of these trials had similar designs. The subjects were between 18 and 60 years of age. They had a neurologist-defined cryptogenic stroke. They had a full cryptogenic stroke workup, and everything was negative except for the finding of a PFO. And then the patients were randomized to receive either blood thinners alone or PFO plus blood thinner, because back at that time, of course, without the benefit of knowing that PFO closure was beneficial, blood thinners remained the standard of care. And what all three trials showed in a very gross way was that over time in this standard type of Kaplan-Meier analysis, the patients who got the PFO closure and the blood thinners had fewer recurrent strokes than the patients on the blood thinners only. This curve was not flat, and we'll come back to that in a little while, but this curve was steeper, and so the patients with the blood thinners had more events. And in all three of the trials, the ultimate difference between the two groups at the endpoint was statistically significant in all three of those trials. The trial data led to FDA approval of two devices, the Amplatzer PFO occluder in 2016 as a result of the data from the RESPECT trial, and the Gore cardioform septal occluder in 2018 as a result of the data from the REDUCE trial. And then that brings us to the REDUCE trial, which is going to be the focus of the rest of our discussion today. This paper was published in the New England Journal of Medicine 2017, as stated. The physician group was made up of interventional cardiologists and neurologists in 63 sites at 7 countries. The trial overall was very similar to other studies, the other two studies, but there were a couple of important differences. In the Gore study, in the REDUCE trial, any size PFO with right to left shunting was allowed. In the closed study, for example, you had to have a large shunt or an atrial septal aneurysm, but that was not the case in this study. In this trial, compared to the others, the randomization was 2-to-1 treatment of the PFO versus medical therapy. And the medical arm of this study allowed antiplatelet therapy only, with the vast majority of the patients only taking aspirin. In the trial, the Gore Helix device and then the cardioform septal occluder, which came out in the midst of the trial, were the only devices allowed. And interestingly, in this study, a follow-up MRI was done in all subjects at 2 years to look for silent recurrent ischemic strokes. So the study endpoint for the Gore REDUCE trial was either a recurrent clinical stroke, defined as symptoms lasting 24 hours or more, or recurrent stroke on imaging. And that led to, the three trials have led to dramatic changes in the landscape since that time. These are new guidelines from the American Academy of Neurology, and now give reasonable, enthusiastic applause for PFO in selective populations. The SCAI itself created a consensus statement on the criteria for operators and institutions to be involved in this activity. And then there were a recent publication which talked about updating the nomenclature to take PFO-related stroke out of the category of cryptogenic stroke. So there's been a lot that's changed just in the last 3.5 years since the publication of those papers. And the world of PFO and stroke is very different now than it was just 5 years ago. And so now we're going to hand this over to my good colleague, Dr. Price, who's going to talk specifically in detail about the REDUCE study.
Bob, thanks so much. Great presentation on the background and where we're at currently with transcatheter PFO closure for cryptogenic stroke, or I should say embolic stroke associated with PFOs, given the new nomenclature. So we have some exciting new data published, as you know, in the New England Journal of Medicine just recently, and that's the 5-year outcomes of the REDUCE randomized clinical trial, which Bob touched upon. And I think it's important, we're putting in these devices in fairly young patients, generally aged less than 60 years, to understand particularly the longer term safety of these implanted devices. So just to refresh, Bob went over this briefly. The aim of the reduced randomized trial was to establish the superiority of PFO closure in conjunction with antiplatelet therapy over antiplatelet therapy alone in reducing the risk of recurrent clinical ischemic stroke or new brain infarct. We'll talk about those two co-primary endpoints. This was randomized controlled and open label. There were 664 subjects randomized in a 2-to-1 ratio, either to closure or medical therapy. And when we drill down into the details of the data, it's going to be important to remember this 2-to-1 ratio, because that means that there are significantly a smaller number of patients randomized to medical therapy. This was a large global trial, 63 sites in 7 countries, but a large cohort from the United States. So I mentioned co-clinical endpoints, co-primary endpoints. There was the freedom from recurrent clinical ischemic stroke through 2 years, adjudicated by the CEC. And there's a second co-primary endpoint of incidence of new brain infarct through 24 months. We'll focus on the recurrent stroke endpoint, recurrent clinical stroke in this presentation. The subjects were followed prospectively for 5 years. So the initial primary endpoint results were reported when patients achieved at least 2 years follow-up. Now all the patients have 5-year follow-up, so we can look back and see the clinical endpoints that occurred. And again, if you're a statistical nut, all these, the co-primary endpoints were adjusted for multiplicity. All right, the eyes and knees, just to drill down even more, because it's important, I think, to look at the eyes and knees, because when we see patients in the office in consultation for transcatheter closure, we need to know whether these patients fit within the reduced trial or whether they don't. And we can explain that to the patient and really robustly explain the risks and benefits of PFO closure. So patients had to be between the ages of 18 and 59 and had to have had the ischemic stroke within the prior 6 months. And again, an ischemic stroke was defined as MRI evidence of infarction or clinical symptoms for at least 24 hours or more. They had to have a fairly thorough workup to ensure that this was a cryptogenic infarction or stroke, meaning no carotid stenosis, no evidence of a hypercoagulable disorder, no other known cause of stroke. I would say, although it says here, no Afib, patients did not proactively or routinely get cardiac monitoring before randomization. I think Bob and I will drill down more on that and discuss that once the results I have here are presented. The patient had to have a documented PFO and no indication other than potential cardiac embolic stroke for anticoagulation. So patients in the medical therapy group either got aspirin alone, combination therapy, or clopidogrel. They're prescribed for all subjects for the duration of the study. So here's the follow-up plan for REDUCE. So as I mentioned, all patients were followed for 5 years, and patients had pretty thorough neurologic follow-up. You see the endpoints there through 60-month follow-up. And all subjects had an MRI at 2 years. So you see the graph here down below, or the chart of neurology assessment, echo and bubble studies, and MRIs. So really all the imaging has been done now, or past 2 years. That was all reported in the 2-year endpoint or the primary endpoint. Now we're looking really at clinical endpoints, neurology assessments at 5 years, and further safety. Here are the baseline characteristics of the reduced clinical trial of the patients enrolled in the trial. Bottom line is there are no significant differences between groups, between closure and medical therapy. Randomization worked. If you look at the types of patients these are, the mean age was around 45 years. A preponderance were of male sex. Very few smokers and diabetics and hypertensives. These are patients who either had controlled or very few risk factors for stroke. So this all makes sense. About 8 out of 10 patients had a moderate or large PFO or shunt. So here's the primary endpoint of the reduced clinical trial at 2 years. So this is what was initially published in the New England Journal of Medicine. In patients randomly assigned to closure, there's a 77% relative risk reduction in clinical stroke by the intent to treat analysis. Okay? And the effect of PFO was consistent across subgroups. And this led to a number needed to treat of only 28 patients at 2 years to prevent a single recurrent stroke. You see the hazard ratio there of 0.23 and the annualized event rates of 0.39 versus 1.71 per 100 patient years. In this initial presentation and report in the NEJM, the overall median follow-up was 3.2 years. So there's already some decent follow-up in this first publication or report. So now let's look at the 5-year endpoints. So 2 key things we're looking at here are freedom from recurrent clinical ischemic stroke through 5 years and safety through 5 years. Let's talk about completeness and crossover, because once you get past the primary endpoint of a trial, there can be issues with keeping patients in the trial and crossover. If you've shown that the therapy works, patients who are randomized to control want to say, hey, I want my hands on that therapy. So let's see what happens. So among the 441 patients who are randomly assigned to closure, there's 2,069 patient years of follow-up. About 1 out of 10, a little bit more than that, prematurely discontinued the study from follow-up. In the antiplatelet arm, there were 223 patients. Remember, a 2-to-1 randomization scheme. There are 950 patient years of follow-up, and 20% of the patients prematurely discontinued. Over the course of the trial, 17% of the control arm crossed over to intervention, that is, got the device. You see there the breakdown after the 2-year primary results. About 11% of the control group crossed over. So when we look at the results, I'm going to show you the intent to treat results, intention to treat. You need to factor in that a proportion of the patients randomized to the control arm actually receive the therapy, so they may be protected. So there's less power to see differences between the 2 groups. The median duration of follow-up overall was 5 years. Pretty tight interquartile range there. So this is solid 5-year follow-up, but again, less total patient years among patients treated medically versus those treated with the device. So here then is the primary endpoint, recurrent ischemic stroke at 5 years, according to intention to treat analysis. So based on how they were randomized, not how they were treated. You see at 5 years, there's a persistent and substantial benefit with device closure in these patients. There's now a 69% relative risk reduction with a highly significant p-value of 0.007. You see the annualized event rates there of 1.26 to 0.39. So the efficacy of PFO closure with the Gore devices were persistent or continued over time to complete 5-year follow-up. How do the event rates differ at the 5-year follow-up versus really the 3.2-year follow-up in terms of median follow-up? So there were no further events in the medical group. There were 2 ischemic strokes in the closure group. So you have 12 versus 8. Remember, it's a 2-to-1 ratio. So there's half the number of patients in the medical group. So if you look at absolute event rates, that's 5.4% versus 1.8%. Looking at hazard ratios through survival curves and long rank adjustment, you have a relative risk reduction of 69%. In terms of mortality, really no difference. 3 patients died in the closure group, 1 patient died in the medical group. In the small print, you can look at the causes of death, none of them related to the device or the procedure. What about DVT or PE? There's been some thought that patients may have a preponderance or an increased risk of DVT or PE in patients getting closure because you're withdrawing sometimes oral anticoagulation or other things in those patients. Well, in this trial, at least, there was no difference in the risk of DVT or PE among patients who are randomly assigned to closure. The absolute event rates there of 1.1% versus 0.9%, spot on the same in terms of the effect size. And finally, persistent or permanent atrial fibrillation. There was an increased risk of persistent or permanent AF at 5 years, 2.7% versus 0.4%. That's a increased odds ratio of 6.2 with a p-value of 0.078, so not quite reaching statistical significance, but the trial is underpowered to see differences, certainly a trend by any means, for more AFib in the patients randomly assigned to PFO closure. Let's talk a little bit more about AFib. So here is a graph. On the x-axis is the time to the first onset of AF in days. And on the y-axis is the duration of atrial fibrillation. So the higher up on the y-axis, the longer the duration. Each dot is a patient, and whether or not it was long-term persistent is in red. So duration of more than 1 year. So a couple of things to take away from this. Number one is 83% of all the cases of AF in this study, in the device arm, occurred within 45%. More than half, about 60%, were short term, lasting for less than 2 weeks, so they were self-limiting. Only 12 patients, 2.7%, had AFib that lasted for 30 days or more. It is interesting, and maybe Bob, you and I could talk about this later, are these patients who have AF onset far beyond the procedural period. So in this case, we're following them out to 5 years. For example, there's a patient here, and I think we should talk about whether that can be mechanistically related or not to the AFib, to the PFO closure. So this is a summary slide, just stepping back at 5 years, but AF or AF-flutter in the device group. So overall, if you look at any AF, not just persistent, but occurring early or late, it occurred in 30 patients, so 6.8%. That was overall at 5 years. At the initial endpoint, at a median of 3 years, it was 6.6%. So very few patients had more AF after 2 years. 12 patients, 2.7%, had AF that lasted more than a month. Of these, there are some interesting analyses using univariate analysis. So associations were with male sex. 11 out of 12 were male. 9 out of 12 were older. They were age 50 or more or older. All of these 12 patients got oral anticoagulation. One patient, unfortunately, did have a recurrent stroke despite being anticoagulated. You see the univariate predictors here, the actual odds ratio. So older age, male sex, prior stroke or TAA, and having a closure device. So that's taking both the control group and the device group. However, just because of the low numbers, it's not a lot of patients. There is no factor that was independently associated with persistent AF on multivariate analysis. So in conclusion then, when we look at the reduced clinical trial at 5 years, in carefully selected patients, PFO closure significantly reduced the risk of recurrent stroke compared with antiplatelet therapy alone over a 5-year period. There was a 69% relative risk reduction in recurrent clinical stroke. The number needed to treat was 25 at 5 years. I think really the biggest takeaway for me is that there are no late occurring device or procedure related complications. Persistent or permanent AF did occur in the device group. 2.7% of the patients had AFib for 30 days or more. We can talk about whether we can do a better job at screening, Bob, or identifying these patients. But I do think stepping back, these longer term findings bolster recent updated guideline recommendations for PFO closure in appropriate patients. So I'll leave it at that, Bob. And why don't we talk about some things? I guess I'll flip it back to you. How do you take the reduced 5-year data and incorporate that into your practice? What are your big takeaways?
The first thing to take away from this is that the therapy is safe, right? It is a safe therapy. There are no long-term device complications, device fracture, erosion. None of those are clinically important issues with this particular device. So that's the most important thing. I think the AF is really interesting. One of the most important things about this trial, which is different than the way we manage and deal with patients in the office today, is that this trial did not require any extended monitoring of these patients to look for atrial fibrillation. So we frankly have no idea if some of these patients had pre-existing atrial fibrillation, which may have increased the rate of AFib in this population. Now, the other thing
I'd also say that, and I agree, and because it was 2-to-1 randomization, you only have 200 some odd patients in the medical group. 2% of 200 patients is just a small number. So that it's underpowered to really compare post hoc looking at differences in AFib.
And the other thing I think that's really important, which you mentioned already, was we believe that mechanistically, the underlying substrate that causes the AFib in these patients is an inflammatory response to the device. There's irritation and inflammation of the septum that occurs as a result of relative motion between the device and the septum. And as the device sticks to the septum and as it endothelializes, that relative motion stops and the inflammation and the irritation of the septum goes away. And that's why when we see these patients in the office clinically, in almost all of them, and this has been my experience with thousands of these patients by now, but in almost all of them, the arrhythmia is resolved by 6 to 8 weeks. And I think that is pretty consistent with the data that was shown in the trial. There are two groups that are outliers in the trial, those that had 30 days or more of atrial fibrillation, which was a subset of patients that got AFib early on, and perhaps, we don't know, some of them had silent AFib before. But I think we have to separate out those late AFib patients who are a year, 3 years, 5 years out, because these patients are aging. They could have been 60 at the time of their implant. Some of them may be 65 by now. And of course, some of them could have had developed atrial fibrillation.
Well, how do you, if you're seeing a patient, you get referred a patient for PFO closure. Do you have a general algorithm to screen for AFib, and what is that algorithm?
So what we do in the office, of course, knowing that the younger the patient, the less likely they are to have AFib, we monitor everybody. So if you are under 60 years of age, the incidence of atrial fibrillation, if you look at the curves of who has AFib, it sort of starts to really take off at age 60 to 65. But if you're less than 60, that incidence is quite low. And we'll monitor those patients for at least 2 weeks. Okay. If you're between 60 and 70, we'll monitor them for at least 4 weeks because we don't want to miss what might be clinically important. And then over 70, is not really approved yet for this group, but most people worry about closing patients over 70 because there are potentially so many other causes of stroke in those patients. But there are plenty of 70-year-olds who are running marathons and are incredibly fit and have no other definable risk factor. In those patients, we'll do a loop recorder in many of them and screen them for a few months before we commit to the PFO closure.
Yeah, I agree. That's pretty much our practice. A couple of things I might do is look at the transthoracic echo. Is there left atrial enlargement? And the patient is 55 years old, 58 years old. That's going to raise your suspicions. Also, there's some good data looking just at the PR interval in the Crystal AF trial. Patients who were not on AV nodal blocking agents, who had any prolongation of the PR interval, were at high risk of having AFib, occult AFib. So those are patients, particularly if they're age greater than 50, you may want to consider longer term monitoring. On the flip side, if somebody's 25, when they happen to get, I've seen this, they get a link when they're 25. They have a big aneurysmal aseptum, big PFO, and they have 2 minutes of AFib at 3 months. I mean, again, we have to be rational physicians here. We're practicing medicine. Using I think our common sense is that the risk of the PFO is probably higher than the risk of that AFib in that patient. So again, something to think about.
Yeah, the other thing that I think is really an important issue that is actually something that I have a couple of fellows working on is that I believe that 6% rate is probably well underestimating the amount of AFib that there actually is. And that's because during these trials, the only way we would know that somebody had atrial fibrillation was if they showed up in the emergency room or in the office with atrial fibrillation. And I'm sure there's plenty of patients who are having short runs of AFib
Both
at
are.
night or et cetera. So what we've been looking at is using the patients who have loop recorders to try to prospectively define what that actual incidence is, and to define really what the duration and clinical importance of these atrial fibrillation episodes is. So I think there's actually a lot of work to do here, because the neurologists as a group are still a little bit frightened about the atrial fibrillation.
Right. I step back. I've spoken with my neurology colleagues as well about this. And I step back and say, despite these numbers, profound reductions in stroke.
Right.
So irrespective of this AFib.
Yeah, that's the other thing, right? How dangerous can the AFib be if the preponderance of patients who got AFib got closed and they had a 77% reduction in stroke rate?
Right. So between the primary endpoint report, which is, they call it 2 years, but it's really 3 years, and the 5-year outcomes, there are 2 stroke events in the closure group, no stroke events in the medical therapy group. What's your takeaway from that?
Again, the power of this study was something that was of a lot of concern while it was going on, because we already had been through the initial CardioSeal study with that device, and that was underpowered. And several other studies were underpowered. The PC trial was underpowered. So we were very worried about the power of this, but there was such a significant difference between the 2 groups that this was, easily powered enough to give us a statistical difference. But that's at the primary endpoint. I think it's really hard, especially as the number of patients starts to dwindle.
Right.
And you have to bear in mind that some of those got the PFO closed, right? So they may actually be better protected than their counterparts in that group, but they're still, based on the intent to treat analysis, counted in the medical arm.
Right. Certainly safe at 5 years. I get that question all the time, is I'm going to have this for my entire life. How safe is it? At 5 years, certainly. You think there'd be some signal for something by 5 years. There clearly is no signal for anything at 5 years. So that's great news.
Yeah. And I think, again, doing a lot of this in the clinic, these patients are fine. So many of them just stop coming after 3 or 4 years because they say, what's the point? I'm fine. I feel good. I have no symptoms, et cetera. So
I'm gonna, while I have your captive audience here, so I'm gonna pepper you some other just questions that have somewhat to do with the 5-year data. But let's talk about shunt size and your interpretation of the data. And the question is, should shunt size play a large role in your decision about whether to treat a patient with a cryptogenic stroke with PFO closure?
So I'm going to answer that in a long and convoluted way, I'm sure. Before these trials came out, before the randomized trials were published in 2017, I think one of the critical features that we used to make a determination was the shunt size.
Right.
Because I think everybody, based on the mechanism of paradoxical embolization, accepted the idea that if it was a pinhole, what was the likelihood that a clot was going to go through once, much less multiple times?
Right.
Okay. So I think that was pretty well established as a criteria early on. And then the closed study and the defense PFO study, which we didn't talk about, but which was a South Korean study, both used large shunts and atrial septal aneurysm as entrance criteria. And those 2 trials had by far the largest benefit to PFO closure. Then when you went back and looked at the RESPECT study and the REDUCE study and did an ad hoc analysis, there's a very nice graph on this in the study, it was very clear that even though the number of patients was very small in the smaller shunt group, that the larger shunt clearly benefited from the PFO closure, and the smaller shunts, it wasn't so obvious. So I think the bottom line is that probably the greater the shunt size, the more prone you are going to be to having recurrent stroke. That being said, it doesn't mean that there are patients with small shunts who shouldn't get their PFO closed because they may still be at risk. Not to mention the fact that TEE, when they're under anesthesia and dehydrated, can dramatically underestimate the size of the shunt.
Right. So I have three things. One, to go backwards from what you said, so common that a patient has a small PFO on TTE and TE, then you do an ICE-guided intervention, injecting bubbles from the right femoral vein, and there's a large PFO, a large shunt. So I think the sensitivity of, or the diagnostic accuracy of transthoracic echo or even TE for the size of the shunt may be quite low. Number two is, not to dig down deep on the statistics, but those subgroup analyses are so underpowered, and there are borderline statistical significance. So I think that there does seem to be a preponderance of greater benefit with large shunts, but that does not exclude a benefit with smaller shunts, as you said. And third thing, David Fowler from Tufts has some interesting data that, and a theory that maybe even small PFOs may be a nidus for in situ thrombus formation, which could, so, right. So I think we need more, we need more data.
Right. And I going back to the echo imaging for a second, I think really the PFO is a dynamic mechanism, right? It's a dynamic structure. And so I think it's really important that patients get Valsalva maneuvers to assess the shunt, because when you strain and then release, the amount of shunt can be dramatically magnified. And under anesthesia with TEE, you might not be able to do that. So in our office, when we're actually screening for PFOs, which we do quite a lot of, we are using we're using transcranial Doppler all the time in the office, because it's very simple, it's very easy, it's very sensitive, and you can easily have them Valsalva, reposition them to sitting, standing, whatever. A lot of people are really interested in the question of why is it that people in the closure arm of these studies are still having strokes?
Well, I think there are several answers to that. First, and you sort of alluded to that earlier, is these patients are getting older over time, and there are other reasons to have strokes beyond a paradoxical embolism through the PFO. So they could be having strokes as they get older for more run-of-the-mill reasons, intracranial atherosclerosis, carotid disease, what have you. The other thing is, going into the trial, not all patients with PFOs and stroke, the cause of their strokes may not have been the PFO. It's a preponderance of evidence. So when I talk with patients before we do PFO closure, I'm very clear. I do this as well before I do LA closure for patients with atrial fibrillation, is that unfortunately there's a lot of reasons why patients have strokes. And we're going to address one of those reasons and just get that out of the way. And then we have to focus on the other reasons, exercise, and reducing your risk of stroke for other reasons, exercise, eating right, controlling your blood pressure as you get older and so forth. So it's a numbers game. And I think, again, we see the event rates in the closure arm much lower than we saw in both in the randomized control group, also in the observational registries before we even did a randomized trial, that we have significant reductions to what were to be expected in patients who are not treated with devices.
Okay, so let me go back.
You agreed with me.
Yeah, I think that's absolutely right what you just said. And I think it's the same reason why we try to encourage our patients, and our neurology colleagues try to encourage our patients to stay on aspirin long term. Because we don't know for sure that the PFO was the cause. all of this, any stroke event that's embolic in nature, it's a probabilistic assessment, as David Thaler always used to say. You don't know for sure where it's coming from, but we're trying to treat what we can, right? And based on the data from REDUCE and from the other randomized trials, it's pretty clear that in the absence of another source, that closing the PFO is a better treatment than staying on medical therapy. All right, Matt. Here's a question that we all face every day. I think we touched on it really briefly a minute ago. Are you concerned about closing PFOs in patients who fall outside of the age ranges that were studied in the trials?
I take a measured approach and make sure that a full workup has been done, and also the patient knows that they are not reflected in the clinical trial data. That being said, just because somebody is 71 doesn't mean they can't have a stroke due to a PFO. So we shouldn't select patients only based on age. But then again, if you have, like we talked about before, if there's a 71-year-old with a large LA with LV dysfunction, diabetes, and hypertension who comes in smelling of cigarettes, I'm not going to close that patient's PFO. Luckily, I live in La Jolla where none of those things apply generally. And my 71-year-olds look like they're generally less than age 60. So no, I have closed several of those types of patients. I think there is a clinical trial ongoing to look at that to get more robust data. I think that you need to be careful to exclude other causes, particularly atrial fibrillation as patients get older. But once you've cleared that hurdle, I think that's a reasonable approach. I have one final question for you.
All right, go ahead.
Yeah, now that we have the 5-year data, and again, a practical question for our SCAI colleagues, practicing interventional cardiologists, pediatric cardiologists. Now that you have this 5-year data, how should we follow up these patients in the office? For example, let's say today I did a patient, 35-year-old, closed the PFO, went well. It's all closed. Do I see this patient at 6 months, a year? Do I need to see them every year to get echoes to see how they are doing? How should I follow up these patients?
Well, I can tell you what we do. It's very difficult to get these young, healthy people to keep coming back for checkups, especially if you're trying to encourage them that they're really healthy, right? I mean, that's right. So we routinely see these patients at a month, 6 months, and a year after the procedure. At a year, we'll do a transcranial Doppler study to show that the PFO is closed. I think we're around 90% complete closure rate, really just looking for large residual shunts that might still put them at risk. But after that, I think we kind of leave it up to the patient's own level of comfort. If they want to come back every couple of years for us to check them and check the device, I don't have any problem with that, but the vast majority of them stop coming. And I think that's okay.
I think it's okay. I think it tells me now that after a year, as long as they have a doctor, I'm not going to be worried about checking them to make sure they're not having some clinical complications of the device.
And I think the 5-year data really helps with that, right? If there are no long-term device-related complications out to 5 years, that's pretty reassuring.
Agreed. Bob, thank you so much.
Matt, it was a pleasure. Thank you to SCAI and to Gore for sponsoring this, I think, pretty fun talk. And we'll see you soon, hopefully in real life.
Take care. Good night.